Miscarriage can be a very traumatic event for any mothers to be, and it is defined as loss of pregnancy before 24 weeks of gestation, or if the gestation is not known when the weight of the fetus is less than 400 grams. This is called an event. Yeah? If you look at mothers who are less than 35 years old, 10 to 15 of their pregnancies will be aborted. But as the mother increase in their age, for example, 40 years old mother, the chance of aborting the pregnancy goes up to about 40% to 50%. And in the elderly mothers who are more than 45 years old, many of the pregnancy are actually being aborted. And again, although we see in our early pregnancy assessment unit, we see bleeding, miscarriages, we see ectopic, we see molar, mind that ectopic and molar are not included in the terminology of miscarriage. Okay. This graph illustrates the importance of age. Kat mana dia punya cahaya tu? Tengah, okay. Cari cahaya, okay. This graph illustrates the importance of age. If you can look at this graph, at the age of 45, a woman is still considered fertile until she is menopause. She can still be able to get pregnant, although the chance of her getting pregnant is lesser with advanced age, but she's still at the fertile age. So, at the age of 45, 90% of the pregnancy will be aborted. And this is actually attributed because of the risk of aneuploidy in the oocytes. As you advance in age, the risk of aneuploidy in oocytes becomes higher. And that's also what we usually counsel our patients when they do IVF, for example. While their chance of conceiving at the age of 40 is less than 10%, because many of the oocytes that are generated are actually at risk of aneuploidy. For example, if you have 10 oocytes collected from a mother who is 40 years old, only probably 2 of the oocytes are chromosomally normal. The rest 8 of the oocytes are actually not normal. And this actually translates into the higher miscarriage rate that you see in the elderly woman. Okay. Now, with regard to recurrent miscarriage, how do you define recurrent miscarriage? If you look, there are many definitions of recurrent miscarriages depending on what criteria was given by the institution. Royal College of ONG and European Society of Human Reproductive actually define recurrent miscarriages as 3 consecutive pregnancy losses, including the non-visualized. I mean, you have a positive biochemical pregnancy, you do a scan, you cannot see, still that is considered as miscarriage. Whereas the American Society of Reproductive Medicine considered recurrent miscarriage when you have 2 or more clinical pregnancy, means that you have to have an ultrasound that defines the pregnancy and subsequently miscarriage, then only you include that as pregnancy. But not necessarily the pregnancy are consecutive. That means you have 1 abortion followed by a live birth, and you have another abortion, that is also considered as recurrent miscarriage according to the ASRM criteria. And because of these differences in terms of definition, you will see that there is also differences in terms of incidences of recurrent miscarriages. But overall, it is estimated to affect about 2 to 5% of couples. And again, you can have primary recurrent pregnancy loss when there is no viable infants at all. Secondary recurrent pregnancy loss when patient has history of pregnancy that is achieved beyond 24 weeks, and subsequently tertiary recurrent pregnancy loss when there is multiple pregnancy losses between normal pregnancies. Okay? Now, the next question is, when do we investigate a patient who comes and see us for recurrent pregnancy loss? According to this article published in BMJ 2000, it is stated that it is reasonable to start investigating after 2 pregnancy loss. Not 3, 2 pregnancy loss. If you have 2 pregnancy loss, it is reasonable to start investigating, especially when the woman is more than 35 years or the woman has a background history of infertility. So it's reasonable to start investigating earlier so that we have a better chance of a successful pregnancy afterwards. So, women with recurrent miscarriages should be seen in specialized clinic. In many centers, they have recurrent miscarriages clinic. We do not have in our setup, but we have the pre-pregnancy clinic at our clinic, where we can actually see all the cases of recurrent miscarriages and work them out to see what are the causes. So there are various causes of recurrent miscarriages. If you can appreciate, among others, genetic, anatomical, immune factors, infection, endocrine, and also if you have exhaustively investigated and do not find any cause, this is termed as unexplained recurrent miscarriage. Okay, let's do one by one. Endocrine. Okay. Poorly controlled diabetic, and you have very high hyperglycemia. Glucose is actually teratogenic for the baby, and that would actually result in higher chance of miscarrying. And so, poorly controlled thyroid disease, they are also at risk of miscarriage. Obesity. How does obesity affect pregnancy? Obesity can affect in many ways. For example, the oocytes that are being generated in obese patients are actually poorer in quality, and so are the endometrium in the obese patient. They are also poorer in terms of endometrial receptivity. So because of that, obesity is associated with miscarriages. And polycystic ovarian syndrome, patient with polycystic ovarian syndrome has higher risk of miscarriages, and this is related to multiple factors. 50% of PCOS women are also obese, so indirectly PCOS are also have problem with obesity, hyperinsulinemia, and hyperandrogenism that could actually contribute to the miscarriage. Okay, so well-controlled diabetes is not a risk factor, and so are the treated thyroid function is also not a risk factor. And 2 recent cohort studies found a high prevalence of subclinical hypothyroidism, that is, if the TSH is more than 2.5, they are at higher risk of miscarriage. But however, to date, there is not enough data to recommend routine screening of thyroid function in otherwise euthyroid women. So based on these 2 cohort studies, it is not justifiable to do a thyroid function test in women with recurrent miscarriage whom you assess clinically they are at the euthyroid state. Well, we go on the second cause of recurrent miscarriage, that is the genetic. 3 to 5% of recurrent miscarriages on one of the partners who phenotypically look normal, just like any one of us, they can become a carriers of balanced chromosomal anomaly. These carriers, they are phenotypically normal, but their pregnancies are at increased risk of miscarriage or live birth with multiple congenital anomalies. So the most common chromosomal anomalies that are found is actually the balanced translocation. Either it is reciprocal balanced translocation, where one arm of the chromosomes are broken, and this chromosome actually switch to one another. So this is reciprocal. And also Robertsonian translocation, where there is breakage and rejoining. So what happened? Translocation carrier, they did not manifest anything. They are perfectly normal, healthy individuals, except for carrying the abnormal genes. But when they produce gametes, they produce varieties of gametes with abnormal, and they can produce offspring, which can be chance of normal offspring is still there, but they also produce varieties of abnormal genetic makeup of the offspring, and these could actually lead to a miscarriage. Okay. So what do we do if your patient has recurrent miscarriages? One of the things we should analyze is the parental karyotype, the karyotype of both partners, and this is done by blood analysis. So it helps to identify a partner that carry a hidden chromosomal problem, as what I've explained before. And chromosome testing of the fetus, again, is an analysis of the genetic makeup of the child. Okay, if you examine, you will extend the chromosome analysis of the fetus, many a time you will find that most of the abortus has chromosomal anomaly. But that does not necessarily mean that the parents are carrier of the genetic abnormalities. Most of the chromosome abnormalities that found on the baby are unlikely to repeat. You only have to do you only have to do parental screening if you send the POC of the fetus and you found that the POC has unbalanced chromosomal abnormality. The one that you saw from the graph just now, you saw that, you know that probably one of the father or mother will be the carrier. And that says that is the situation where you send the cytogenetic analysis of the mother or father. Okay? And finding of an abnormal parental karyotype, what should you do? You should actually refer these patients to see a geneticist. So geneticists are very rare. You have one in Penang for northern region, so you have to refer to Penang. I've got a few patients that we refer and the appointment is very, very long because there are only rare geneticists around. So the appointment is very, very long. Yeah? So meanwhile, what should you explain to the patient? The chance of conceiving a normal child is still there, although the chance is actually low. Another option that we can offer to the patient is pre-implantation genetic diagnosis, especially in infertile couple. Okay? So I will just illustrate what is PGD. PGD must be done in a setup where there is a IVF. That means IVF and PGD goes together. So what you do is that you collect the egg, fertilize with the sperm, and let it become embryo. So usually a day 3 embryo would have 8 cells, and day 5 embryo what we call as blastocyst. So we biopsy a single cell and send for chromosomal analysis, what we call as prenatal genetic analysis or prenatal genetic screening. So after we have biopsy, we freeze the embryo. Okay, we didn't transfer that sample, we freeze the embryo and send over the genetic material from the biopsy blastoma for analysis. So from there, we will be able to say whether embryo A, B, C, D, E is normal or not. Which of the A, B, C, D, E, F, G is actually a normal embryo, and only normal embryo will be transferred back to the mother. Okay, having said so, this is a technology, but this is an expensive technology. We don't have it in our government setup. IVF is not with PGD in our government setup. In northern region, we have 2 centers doing PGD, but their quotation is very high. So 5 embryos, 8,000. Okay, that does not include the IVF. For IVF and stimulation is about probably 15,000 plus 8,000, so probably 23 to 25 or 28,000. That is the figure that you should tell patient. It's worth Viva, second-hand Viva. So that's the price that the patient has to be explained if she wants to go for PGD. But if you go for recommendation by RCOG, you should also tell the patients that the chance of conceiving normally is still there. So it is better for them to also try conceiving normally if budget or money is an issue for them. Okay. Right, antiphospholipid syndrome is what we have heard from our rheumatologists just now. One of the things that can cause recurrent pregnancy loss is antiphospholipid syndrome. It is estimated that prevalence will be about 5 to 20%. There are antibodies circulating, there is anti-cardiolipin antibody, lupus anticoagulant, and anti-beta-2 glycoprotein 1 antibody. For you to be able to diagnose APS, you must have 1 clinical and 1 laboratory criteria. The laboratory criteria being the 3 antibodies that I've mentioned just now, and it should be positive on 2 occasions, taken at least 12 weeks apart. And for the clinical criteria, you either have a vascular thrombosis or obstetric morbidity. And the features of obstetric morbidity will include a pregnancy loss, a preterm birth, a severe preeclampsia, and also placenta insufficiency. Okay, so these are the criteria for us to diagnose patient as having APS. Okay, So how does APS cause recurrent pregnancy loss? So what antiphospholipid antibody does is that it targets the trophoblast cell, causing an impact trophoblastic invasion. When the trophoblast does not invade appropriately, the secretion of HCG, which is produced by the trophoblast, becomes low, the secretion of growth factor becomes low, and that can actually contribute to the miscarriage. Same goes with in situ trophoblast apoptosis, inflammatory response of maternal-fetal interface, and also vascular endothelial causing abnormal formation of spiral arteries. So these are the ways how antiphospholipid antibodies in patients with antiphospholipid syndrome affects the pregnancy, resulting in various phenomena of the pregnancy. Among them include recurrent miscarriages, preterm delivery, severe preeclampsia, IUGR, placenta abruption, and also arteriovenous thromboembolism. Thrombosis. Okay. As what we mentioned just now, what are the treatment for patients who are confirmed to have APS, antiphospholipid syndrome? It has been noted that heparin and aspirin increase the live birth rate compared to aspirin alone. And aspirin can be started in patients with APS. It can be started before pregnancy, not at UPT positive. It can be started before pregnancy itself and continue throughout. And heparin comments on confirmed pregnancy. Low molecular weight heparin is what we are using now, gives similar efficacy and safety. And the use of prednisolone and intravenous IVIG is of no value. And live birth rate in women without treatment is less than 10%. Whereas in patients who receive treatment with heparin and aspirin, the pregnancy rate can go up to about 70 to 75%. Anatomical factors. So you have a problem with anatomy causing the pregnancy not being able to continue. See? So among anatomical factors is actually either the uterine or the cervical. So the prevalence of anatomical abnormality is actually quite high. It is reported between 19% to 37.6%. And miscarriage usually tend to be later, and this is probably related to cervical incompetence. Untreated uterine anomalies, if you find uterine anomalies, for example septum, but you don't do anything, the chance of the pregnancy going to delivery, live birth, is probably less than 50% chance of term delivery. So how do you diagnose a patient with uterine anomaly or anatomical factors? The modalities is actually by ultrasound, whether you do a 2D or 3D ultrasound, 3D being a better mode of diagnosing uterine anomalies, and subsequently confirmation by doing a cystoscopy or laparoscopy. Okay. In this various study, it is noted that the prevalence of uterine anomaly is between 19% to 43%. Depending on the modalities, how you diagnose, and you use office sonography or office plus 3D ultrasound. Okay. So in this meta-analysis of 25 studies, it is noted that among the uterine anomalies that contribute to recurrent miscarriages are the septate uterus and also the biconate uterus. These are all abnormalities from embryology. In embryology, we're supposed to have the luminary duct which fuse, and the central body are supposed to get lines and everything. But in this abnormality, the central body fail to lines. So you still have this fibrotic element at the center, and imagine that the implant were to get implanted on these fibrotic structures, so it will not be a healthy pregnancy, and that can result in miscarriage. So it is noted that septated uterus give a risk ratio of 2.65 and biconate uterus give a risk ratio of 2.32. It has a significantly increased probability of first trimester spontaneous abortion compared with their controls. However, other anomalies of the uterus, for example, you have unicornate uterus, you have diadelphys, you have two sets of everything, you have two uterus, two cervix, and occasionally two vagina, that does not contribute to the miscarriage. you have an arcuate uterus, that also does not contribute to the miscarriage, but the septate and buccal uterus are the ones that actually contribute to the recurrent pregnancy loss. So what we will do with the septate uterus, in this Cochrane collaboration, the operation called metroplasty. Metroplasty is an operation to resect the septum, and they do it via hysteroscopy, metroplasty. They noted that whether we do metroplasty versus you don't do anything for women with recurrent miscarriages having septate uterus. So what was noted that hysteroscopic metroplasty in women with recurrent miscarriage and septate uterus have a positive effect on the pregnancy outcome. Okay, the next thing is uterine polyp. Many a time when we do ultrasound, especially transvaginal ultrasound, sometimes you'll be able to appreciate hyperechogenic substance within the endometrial cavity, and this usually will be confirmed by doing hysteroscopy. So endometrial polyp is associated with pregnancy losses. A meta-analysis of study that used hysteroscopy to diagnose polyps reported them in 2.4% of patients with recurrent pregnancy loss. And because polyp prevalence increases with age, comparison among investigation at this patient of different age are actually delicate. But what we noted that this removal of the polyp will actually increase the chance of pregnancy. So hysteroscopic polypectomy remains the treatment of choice. So there's no difference whether you do scissors or you do sectoscope and so on. But the American Association of Gynecological Laparoscopy recommended removing polyps in infertile women to improve fertility outcomes. Cervical incompetence, that's the other one of the factors that can contribute to recurrent miscarriages. And usually from the history, it is mid-trimester miscarriage. And diagnosis is usually based on history. Patient present with painless labor, and suddenly she feels like something coming out, and there's baby coming out. So it's usually based on history of late miscarriage or early preterm birth, preceded by painless cervical dilation. And there's no diagnostic criteria under the WHSG or other measurements to say whether the patient has cervical incompetence. But inter-index pregnancy with a history of suggesting cervical incompetence, if you do TVS assessment of the cervix and you noted that the cervix is shorter than 25 mm, then there is a high prediction that the patient is going into abortion, then a cerclage is actually needed. So this is how a cervix looks on transvaginal ultrasound. You can measure the cervical length. If the cervix is more than 2.5 cm, the prediction of delivering a preterm birth is actually lower. But if you have a shorter cervix with a V-shape funneling of the amniotic fluid, then you know that the chance of abortion is actually higher, and you can actually do a cervical cerclage for these patients. Fibroids. Does fibroids affect pregnancy in terms of increasing the chance of miscarriages? It depends on location of the fibroid. Fibroid, you can have varieties of location of the fibroid. You can have pedunculated fibroid, intramural fibroid, submucosal fibroid, and subserosal fibroid. Pedunculated, subserosal, and intramural fibroid usually does not affect the pregnancy. But the one with submucosal fibroid, yes, definitely it will have an effect on the pregnancy. So a meta-analysis of study that used hysteroscopy and pseudo-hysteroscopy to diagnose submucosal fibroids reported them to be, the prevalence is about 4.5% in patients with recurrent pregnancy loss. And this study, which was done, 966 patients investigated in the tertiary reference center for women with more than 3 consecutive miscarriage. It is noted that 8.2% of women were found to have fibroids, and submucosal fibroids was 2.6%. And what it is being recommended is that intramural fibroids may be associated with reduced fertility and an increased miscarriage rate. Submucosal fibroids are associated with reduced fertility and an increase in miscarriage rate. Now, the intramural fibroids, does it have a size limit? Usually, what we do is that if the size is more than 4 cm, we would recommend removal of the intramural fibroids because that will have a positive impact on subsequent pregnancy. So, whether resection improves pregnancy loss, you can appreciate here, with the prior resection, the mid-trimester loss is 21.7%. After resection, there is no mid-trimester loss. So, it shows that resection of a fibroid actually has an impact on the ongoing pregnancy. Okay. What about uterine adenomyosis? Yes, if you have uterine adenomyosis, it is a negative effect on the ongoing pregnancy. This is extrapolated based on the context of IVF. And what is noted is that the ongoing pregnancy rate will lesser in patients with adenomyosis, and the miscarriage rate was higher if a patient has adenomyosis. So how do we treat adenomyosis? We cannot go into surgery on adenomyosis because there's no capsule. It's not like fibroid. Yeah. So what we usually do in our context of infertility, we'll shrink the adenomyosis. How do we do that? By giving GnRH and Alor. That means we make patients become amenorrhea, then we shrink the fibroid, and that actually can increase the chance of live birth. Yeah? So this is what we call as ultra-long agonist protocol. Usually 3 to 6 months of agonist followed by stimulation for them to get pregnant. The indication for adenomyomectomy are not qualified. That means you don't have technically that procedure, what we call as adenomyotomy, is not even qualified as a procedure. Okay. Infective agents, routinely people used to say torture screening. It is no longer recommended. Torture screening should be abandoned. No evidence for infective agents as a cause of recurrent pregnancy loss. Some evidence treating bacterial vaginosis reduce second trimester loss. Yeah? That means you have second trimester loss, there is still evidence to treat the bacterial vaginosis with antibiotics. Unexplained infertility, a significant proportion of patients, after all the investigation that we have done the ultrasound, we have sent for cytogenetic analysis, we have sent for thrombophlebitis screening, it came back as negative. So we say that this patient is unexplained. Wallahu alam. We do not know what is the cause. Yeah? So what do we do to these patients who are unexplained? They have an excellent prognosis for future pregnancy outcome, even without pharmacology intervention. Successful pregnancy with tender, loving care, supportive care can be around 75%. But prognosis of course is lower in elderly women and also those who have multiple miscarriages in the past. Okay, you all want to go for lunch, right? This is a lunch-sponsored symposium. Either you like it or you don't like it, you have to listen to this progesterone talk. Okay, alright. 5 minutes. Okay, this is. I need to tell you about role of progesterone. Yeah, because not only because this is sponsored by Abbott, company who manufactures progesterone, but also for our understanding. We know progesterone is very important in maintaining pregnancy. Progesterone is produced by corpus luteum. Yeah? This is in our menstrual cycle. If you can remember, you have a corpus luteum that being degenerated, but if you have a trophoblast being invaded into the myometrium, that trophoblast will produce HCG, and this HCG will maintain the corpus luteum, so that the corpus luteum will continue to produce progesterone. So it is important, it shows how important progesterone is in sustaining the pregnancy. So progesterone prepare the endometrium, decrease the contractility of uterine muscle, regulate the cellular immunity, yeah, and mediates uterine blood flow and uterine endothelial adaptation to pregnancy. A classic study that no one will repeat to see the role of progesterone is that one of the studies that was done, I think about 30-40 years ago, where they remove the corpus luteum of a pregnant mother. Yeah? So when they remove the corpus luteum, the pregnancy will be aborted. So this shows that corpus luteum and progesterone is something which is mandatory for pregnancy progression. So we know that progesterone also are being produced initially by the corpus luteum, and subsequently the placenta at around 8 to 12 weeks will take over the production of progesterone when the corpus luteum had finally regressed. So this is a critical area where deficiency of progesterone can actually cause a pregnancy loss. Okay, so again, evidence to say that progesterone is needed. One of them is the study that I mentioned just now. The second one, if you give mifepristone is progesterone, it blocks the progesterone receptor that will end up in abortion. Yeah? And defective corpus luteum in IVF, ART, will produce low levels of progesterone, therefore higher chance of abortion. So there are a few studies which has been done to show that progesterone is important in patients with miscarriages. One of the studies is progesterone and duphaston by Haas and Ramsey 2013. 14 studies regardless of gravidity or previous miscarriage. There is no evidence of reduction of miscarriage by progesterone, but a subgroup analysis show that recurrent miscarriages was actually lower when the group was given progesterone supplementation. So another study which was done by Professor Al-Zibdi from Jordan in 2005, progesterone in the reduction of recurrent spontaneous abortion, is a randomized control study. 180 pregnant women with at least 3 previous unexplained consecutive miscarriage were given either oral duphaston, intramuscular HCG, or no additional treatment. So it is noted in this study, patients that were given dydrogesterone or HCG will have a lower chance of miscarrying compared to no therapy. And this is again repeated in this study by Kumar et al. In 2014, oral dydrogesterone versus placebo in recurrent spontaneous miscarriage. So again, this was given up to 20 weeks, and it has been shown that without treatment, the chance of recurrent miscarriages is higher compared to patients who were given dydrogesterone. So, based on this, in 2015, the European Progesterone Club Guidelines for the Prevention of Recurrent Miscarriages has given a few recommendations, and one is that for women presenting with a clinical diagnosis of recurrent miscarriages 3 or more, there is a reduction in the rate of miscarriages with the use of dydrogesterone. This is a consensus-based recommendation. Okay, before I stop, I must say this. So everybody were eager. Everybody was saying that, wow, we have a solution for this. So we are giving progesterone support for our unexplained recurrent miscarriages. Why don't we do a bigger study to see what are the effects? So PROMISE is actually one of the latest study that was done recently, published in 2017. So PROMISE is actually a study to look whether giving progesterone support will actually reduce the chance of miscarriages. So it is a multi-centric study. It was done in 36 centers in UK, 9 centers in Netherlands, with the intention to show to us convincingly that progesterone would be a better option. But unfortunately, the result of PROMISE showed otherwise. One minute, okay? Otherwise you cannot get our lunch. So the result shows that the live birth rate in the progesterone group was 65.8%. Remember, this includes 1,568. So this is a big study. So the live birth rate in progesterone group was 65.8%, and the placebo rate, that was not given any treatment, was 63.3%. So there is no significant difference. Again, we are left here with puzzle. Either to give or not to give progesterone support. If you give, you will add to cost implication for cases in unexplained infertility. But if we give, this big study show there is no effective data to support. So what I usually do is that I will counsel the patient. What we also know from PROMISE is that dydrogesterone has no negative effect on the progress of pregnancy. You need to say it is a safe drug. Yeah, and we are giving a lot in our IVF patient. So what we can say to our patient, look, you have 3 miscarriages in the past. There is this study, previously dydrogesterone study shows positive effect, but this study shows that this is equivocal result. So do you want to get the treatment? So let the patient decide, because whatever evidence that we have today are still way for us to make any conclusion. So I come to the end. So of course, recurrent miscarriages is actually a topic that need further research in certain area. For example, the progesterone which we have discussed, the uterine septal resection in septic uterus, whether it is okay to do open or hysteroscopy and so on, the role of natural killer cells and cytokines. So I leave you all with these questions. So I hope I've been able to highlight on the issues of recurrent miscarriages, the causes and everything, so that we can actually refer the patient and treat them accordingly. With that, I thank you.